Well, I feel like that panel did a great job of addressing all those questions and subjects. The only thing that I feel like I should add to, and this is only to clarify the question that came from somebody through Kathy, is why do we think that having a whip is good for the safety of the horses? And so I'm going to compare young horses to 2-year-old children. And for those of you who have been around 2-year-old children, you know what it's like to try to keep their attention sometimes. And so part of raising a child effectively is letting them know that there are consequences to pay for not behaving. And the reason why we want them to behave is because we want to keep them safe. And it's the same way when you get young horses at the racetrack. They have a short attention span. They want to look that way and then go that way, and they want to dart that way. And so the whip is there to sort of tap them on the shoulder and say, no, not now, pay attention to me. No, not that way, we're going this way. And so that's why it is important, I feel, for riders to have a whip when they're riding in a race, when they're on the racetrack with the horse, just to remind horses of expected behavior. And beyond that, I think our panel addressed the rest of the questions fabulously. So we'll move on, and from a panel of jockeys, we're going to address the return to ride protocols, which essentially means the process of evaluating when or if a jockey is ready to return to riding after an injury. And uniquely qualified to discuss this is Dr. Carl Mattacola, Professor, Athletic Training Rehabilitation Services from the University of Kentucky. Dr. Mattacola.
Good afternoon, thank you. I'm going to do really 2 or 3 things, and again, thanks for allowing me to come speak to you today. One of the, I really have 3 objectives. The last few years I've come and spoke relative to the jockey injury database, where we've been collecting injury data on jockeys, and from that, what's transposed is that we've expanded the conversation to talk about management. And this January I had the pleasure of working with the Jockey Guild and the Jockey Club and several entities that have been really supportive to basically create a management program to return and to evaluate jockeys following a concussion. So I'm going to outline that really quickly, and then I'm going to present basically a return to ride protocol that I've derived or sort of modified from some of the recommendations. So in general, concussion is in the news. Many of you all know probably as much as I do about concussion because the information is so readily available. But just really quickly, a concussion is a disturbance in the brain. It has a series of symptoms, and most of those resolve within 3 to 7 days. But and those specifically revolve around cognitive impairments, balance impairments, and physical function. So if we look at other sports, and if we look at society today, there are standardized protocols for individuals relative to concussion management. And if you take your, if you work from a hierarchical standpoint and look at professional sports to collegiate sports to high schools, and even in Kentucky, in Fayette County, we have athletic trainers that are in the middle schools that provide concussion management. And so what's interesting in the horse industry is, particularly for jockeys, is we're lagging a little behind there in that there isn't a standardized protocol necessarily. But the cool news and the good news is that we were funded through several entities, University of Kentucky College of Health Sciences, which where I'm from, Churchill Downs, Keeneland, Turfway Park, Ellis Park, Kentucky Downs, the KTA, Breeders' Cup, the Jockey Club, TOBA, and NTRA. All those groups put in money for a pilot program where we're going to provide a healthcare professional who will be at the Kentucky tracks to provide a baseline assessment for concussion as well as a return to play. And so many of you already know that several years ago that the Jockey Health Injury information system was put into place. And that was basically a means of computerizing information relative to jockeys' health information so that if they were injured, that information could be transferred to a medical facility. For example, if somebody had an allergy and they were unconscious and were shipped, that information could be sent to a medical facility to make sure that person had the best care. The challenge with that is the jockeys need to be available and need to enter that on a voluntary basis. One of the positives of this pilot protocol that we have is that the individual that we're going to put in place will help make sure that we capture some of that information a little better. So it's the jockey's responsibility to help and to update that information, and we're going to put someone in place that's going to help make sure that we can do that more systematically. So here's the cool thing. So we've got the funding for this individual. If a jockey is injured and we have that information in the Jockey Health Information System correctly, then that information could be pushed forward in the case of a medical emergency. The part that's new is that we're going to place someone in the tracks to do baseline testing. And so what that involves is they're going to be there to provide some standardized assessment for concussion that we could then use if somebody is injured. And I'm going to go through the procedures that we have sort of put in place. So we're going to make sure that we have someone that's available that can identify and test somebody for a concussion. All jockeys must be available to this medical advisor prior to riding. And so the way we've set this up is that they're going to come, be evaluated, and we want that to happen within a 12-month period. So annually, we'd like to get a baseline assessment on all the jocks that are riding in the Kentucky tracks. If the baseline assessment has not been performed at the current track or entered into the health information system following completion at another track, then the medical advisor is going to require a baseline assessment prior to riding. So this is new. And so as jocks come to the tracks, particularly in Kentucky for the first time, we're going to need to coordinate the best of our ability that they get a baseline assessment before they ride. The baseline assessment is going to consist of several components. One of the evaluation tools we're going to use is something called the SCAT-3, which is basically a neurocognitive symptoms evaluation test that will provide information that we can use that's a little more standardized than typical signs and symptoms. So the baseline assessment information is going to be uploaded into the health information system for comparison after an incident. After an incident where a jockey sustains a fall or exhibits signs and symptoms or behavior relatively consistent for a concussion, then we would reevaluate them. And the positive of that is that we would have that baseline information from the previous test. So I use the example of if you know or have an annual physical and your blood pressure changes from year to year, you always can go back to that previous year to determine if that change was within normal limits or if that's something that you would want to be concerned about and take action. And this is a very similar component. The other thing that we're going to have in place is we're going to have an informational educational component for both the stewards and the clerk of scales. So if somebody does come off or the clerk of scales notices something amiss, we're going to ask them to notify the stewards or the medical advisor so that that individual could be identified and assessed. Our concussion protocols are going to include, but they're not going to be limited to just the symptoms and physical, and they're going to include but not be limited to the following: symptom assessment, physical and neurological exam, a cognitive assessment, and a balance examination. Again, we're going to use the SCAT-3, and that is going to be an additional piece of information that we can use, and again, will provide us some baseline information. And so if the medical advisor determines that the person did suffer a concussion and the SCAT-3 helped confirm that, they would have them sit out at least a race and reevaluate to make sure that any signs or symptoms have either resolved or they would refer them accordingly. And so the SCAT-3 has several components to it. Basically, there's several signs and symptoms that are assessed relative to consciousness, balance and motor coordination, disorientation. There's a component where you'll assess short-term and intermediate memory, as well as other signs and symptoms while they're performing that test. And this is just an example of the balance component. If a jockey is removed for the remainder of the day, medical clearance must be provided prior to being returned to ride. And this would be a standard protocol that you would find in most universities and high schools, and certainly nowadays in middle schools even. All jockeys shall require clearance by the medical advisor or healthcare provider prior to being allowed to return back to ride. And the other component we're working on that we'll hopefully have in place in the next year is basically a return to ride authorization form that we can use that would be standardized between tracks, because obviously jockeys will often move from one track to another depending on the race card. So the second part of this that I really wanted to highlight is the return to ride. So in 2012 in Zurich, there was a group of individuals and researchers and physicians that got together and basically created the guidelines for concussion management. In these first series of tables is the general guideline for return. So whether it's your daughter or you, a loved one, this is basically the graded return to play or return to participation that is recommended for anybody that has a concussion. And it's 6 stages, which moves from no activity to a light aerobic activity. So if we're looking at this table, it's going to be a consistent table for the next series of slides. We have our rehabilitation stage, and in this case, it's no activity or light aerobic activity. What types of exercises or what types of movements could be recommended, and what's the objective of each stage. So typically with a concussion, the early stage is rest, both cognitive rest and physical rest. And there's a lot of information, a lot of individuals doing research relative to what is the best way to return. Should it be complete rest? Should it be gradated rest? And or how much should exercise be monitored? Right now, the recommendation is complete rest early on until symptoms subside. And then you would move to a light aerobic exercise, so walking, swimming, something that stays below 70% of your maximum heart rate. So trying to increase that exercise, and again, remaining in a symptom-free zone. The next 2 stages are basically sport-specific exercises and non-contact training drills if you're thinking about competitive sports that might have contact in them. So the exercises would be to begin doing some functional exercises that would be specific to your sport. It might be cutting, it might be passing, and it might be drills in soccer, again, avoiding any impact. And the goal of this stage is to add movement and still increase heart rate and see if that exacerbates any symptoms. If the individual is symptom-free, then you'd move on to the next stage. And in this case, non-contact training drills. So more complex drills, you might have people running patterns, passing drills. You may start progressive resistance training in the weight room. Again, you want to increase exercise, work on coordination, and increase load, all trying to remain within that symptom-free zone. And if you do have symptoms, then you would back off the next day, decrease the amount of time that you did it the previous day until you're symptom-free. The last 2 stages are basically full contact, so allowing someone to go back to practice and develop those skills and the coordination relative to practice as long as they remain symptom-free. Of course, they would need medical clearance prior to that stage, and then the very last stage is return to play, so allowing someone back into a game. And if you think about this, in most cases, the signs and symptoms of a concussion will resolve within 3 to 10 days. Typically, most will resolve between 7 and 10 days. Now, here's the difference. Hopefully y'all can read that. We took this information and we put it into a return to ride. And what I did was I used the Zurich guidelines and I combined it with some of the recommendations from some of my colleagues at the University of Kentucky. And they created a cool brochure called Saddle Up Safety Return to Ride. So, and I have a link in here later on if you're interested in that handout. In addition, one of our colleagues at Pimlico Raceway, Dr. Kelly Ryan, who works for MedStar, has actually added some specific exercise recommendations that they use and that she's been using for return to ride. And so what's really interesting is as much as we know about concussion, we still have a long way to go relative to the evidence of why we specifically perform a particular set of exercises. So in this case, if you're looking at return to ride, again, the first stage is no activity, so any person should be symptom-free for 72 hours. Light aerobic activity, so light cardiac training, no resistance training. In this case, 30 minutes on a stationary bike or a jog would be recommended. So that's what they're doing at Pimlico right now. And during that return to play protocol, or return to participation, or return to ride, they would need to be symptom-free. My colleagues at UK have also put some examples in there. And this light activity would be equivalent to grooming and feeding if you compare that to the number of calories burned per hour. Equine-specific exercises, so the next stage would be exercise with no potential head impact. So a 30-minute simulated ride on an equine sizer is recommended. Add movement, strength, and balance. And my colleagues at UK tried to find an equivalent to that, which would be basically groundwork, barn work, cleaning stalls. Again, no impact, but increasing the amount of activity and heart rate. Light riding, so a 30-minute mounted individual trot on a horse that's very safe. Again, getting into that movement, increasing the heart rate, getting into sport-specific exercises so that you can regain your balance. And then return to full riding, no competition. So again, all exercise performed in a controlled manner. Specifically at this time, the individual would be allowed to gallop a simulated race. So getting out and working on the horse, riding with a helmet, all gaits on a reliable horse in a similar environment would be the equivalent if you were a non-racing equestrian. Return to competition, basically return to riding. Again, obviously wearing a helmet, if, hopefully if you had a concussion and you're in a non-racing equestrian event. So just a couple of references. The Saddle Up Safety link will be available, and I thank Dr. Kelly Ryan from MedStar for some of the information she's provided me with their return to ride, and my colleagues UK and Saddle Up Safety, and then much of those tables were taken from the consensus from Zurich in 2012. A cool note is several of my colleagues have submitted some abstracts to the next consensus, which is going to be in Berlin, Germany in November. So we will have some Kentucky representation and some equine representation at that, and they will be reviewing the guidelines and making recommendations for the next progression related to concussion. So in conclusion, baseline testing and standardized concussion protocols are needed to diagnose acute concussion. Specifically, they should include an assessment of a range of domains, clinical symptoms, physical signs, cognitive impairment, neurobehavioral features, and sleep disturbances. So those are all components that should be incorporated with an evaluation. Return to ride protocols are necessary. Right now, the evidence is based on graded exercise, and there's definitely a need to look at these from a more evidence-based perspective. And so one of the things we're interested in doing is beginning to look at heart rate requirements for when people are riding and tie those into these return to participation protocols or return to ride protocols. Thank you. I want to highlight we have, last year I think I highlighted that we had a new dean and we had a new research institute at UK, and that is underway. And so we're excited to be a resource for jockeys and for the equine industry. And thank you.
All right, yeah. We've actually had quite a few questions, but I'm going to just give you one kind of big one, if that works. So one of the questions was related to the, you had mentioned doctors being on grounds and those sorts. And would an EMT or paramedic be able to handle the return to ride protocols? And with the amount of tracks, how will we be able to get a qualified person at those facilities? So kind of a two-part there.
Yeah, two good questions. So could an EMT certainly, particularly if they were versed and I think familiar with the track as far as having a relationship with the stewards and the clerk of scales. Ideally, you would want someone that has a relationship with the jockeys and the whole health information system. So I think that the answer is yes, if they were qualified and trained, and then I think the intricacies with how you would work it out. Great question relative to the tracks. The idea of this pilot project in Kentucky is that we can put somebody in place and we can control the management and we can control whether or not people are baseline tested. And it's going to give us an opportunity to really work through the logistics of providing somebody. Our long-term goal or vision would be that that this could then be rolled out or would be continually rolled out regionally and nationally and become a standard of care. Great, thank you.